We are live, ma'am.
Good evening and welcome everyone to the DOS-PEP third module. As you all know, we are currently in the Strabismus and Neuro-Ophthalmology module. And we have an eminent speaker, Dr. Rashman Gandhi, who will be taking the 21st class of this module and is going to be talking about an important topic, that is disc edema. We'll be having Dr. Gunjan Saluja, who will be moderating the session, and will be carrying forward the discussion with Rashman sir. And Rashman sir, as such, needs no introduction. He is a prominent neuro-ophthalmologist who is a consultant and director at Center for Sight Eye Hospital in Hyderabad. He has done an FRCS from Edinburgh and Glasgow as well, and he's at various leadership roles and is working as a director in this Cygnus LLC in UAE, also a director for the Axon MedTech Private Limited, and also he's a managing director for the Foresight Worldwide company. And primarily is looking after the clinical work in neuro-ophthalmology department of Center for Sight in Hyderabad itself. And he is also fellowship director and board member for the World Headache Society. He's been a founding member of the Indian Neuro-Ophthalmology Society and the country director for the Davos Alzheimer's Collaborative World Economic Forum Initiative. He has various publications to his credit and multiple national, international presentations in the field of neuro-ophthalmology. And I think it's going to be a great session. We'll be hearing from Sir on this important topic of disc edema, which is very important for the postgraduates to understand. Sir, I think we can hear from you. You can share your slides and start your presentation.
Thank you so much, Priyanka. Thank you so much for that lovely introduction. And thank you, DOS, the entire team at DOS, Pranita, Prafulla, and other people for inviting me. It's really an honor to be talking on this forum. So today, as Pranita mentioned, we are going to talk about a very important topic, which is on the disc edema. Now, before we move on to the subject itself, let's take a step back and say that what are the 7 different attributes in a disc that we are supposed to examine in every patient, and then the deviation in the form of edema or other pathologies can be easily understood. The first and foremost, the striking feature that generally we observe when we look at the disc is generally a color, right? And which is pinkish in color, as you know. Size and shape are more subjective. However, we know that, let's say, for example, myopia can have a different shape of the disc. This can appear tilted. Sometimes, why it is important for us to know this is that sometimes some of those tilted discs can be a little hyperemic, giving us an illusion of that disc being edematous. Size of the disc has no direct correlation with current topic, but we'll talk about it a little bit. Especially a disc which appears smaller is very important for us to know as an ophthalmologist, because it can be a hypoplastic disc. Now, what is a clinical way of confirming that we are dealing with a small disc or a pathologically small disc, which is a hypoplastic disc, is to see what is the distance between the disc and the macula. So if you draw a horizontal line from passing through the center of the optic disc and say how much approximately, how many disc diameters is the distance between the disc and the macula, and if that is more than 2.5 disc diameters roughly, then you know that you're dealing with a small disc or a hypoplastic disc. Now, what is the importance for us as an ophthalmologist to know about hypoplastic disc? Because hypoplastic disc can be associated with midline abnormalities in the brain. Sometimes they can also be associated with growth hormone deficiency. And if picked up early, if we examine a child found to have a hypoplastic disc, and if you pick up a growth hormone deficiency early, then you can intervene and make sure that that child's growth, otherwise for life, is normal. The important aspect for today's class is disc margins. The early disc edema can only show a blurring of disc margin without having a clear-cut fluid or elevation of the disc, and that's the reason why disc margins become important. While the cup disc ratio traditionally is described to be important for glaucoma, we also need to understand that a filled up cup can be seen in patient who has a true disc edema. Neuroretinal rim and blood vessels are more commonly again attributed to glaucoma and other pathologies. However, as we go along in the talk, we'll talk about the importance of examining vessels in the patients with optic disc edema. And peripapillary area will give you a clue as to what's going on. Let's say, for example, if you have those concentric rings around the optic disc in a patient who has an edematous disc, you know that you probably are dealing with patterns lines, which are generally seen in papillary edema. So that's about a normal attributes that you need to examine in a patient with optic disc. Now, an optic disc will react to insult in one of these three ways. In an acute phase, in most instances, it will swell up. If the insult which has caused this swelling does not go away, or if it's not treated, or if it's severe, then by 4 to 6 weeks, the optic disc color would appear different and it will appear pale. And then after that, the optic atrophy will set in. And if the main pathology is only the pressure difference between the eye, the brain, and the other pressures, blood pressure, then the disc will lead to cupping. And we are talking about only the first one today, that is swollen disc. So now let's look at the approach to these patients by examining few patients. So we have a 34-year-old female. She comes to you with a routine eye examination. She does not have any problem as far as her visual acuity is concerned, and there are no other attributable or relatable neurological symptoms like headache. Her visual acuity is 6.6. And this is her first ophthalmic examination. When you look at the optic nerve, one optic nerve appears like this. The other eye is normal. So now the question comes in as to what do we do? How do we deal with this? This disc surely appears to be an elevated disc, but the question is it really relevant? What are the ways by which we can approach this patient of disc edema or edema of the optic disc which looks edematous? So that's the scenario number one, when you have a patient with a elevated looking disc with no other historical factors which will contribute to this optic disc edema. So you look at the history, specifically ask for history of headache or visual disturbances. We perform the optic nerve function tests, and then if the need be, you look at the investigation. These are three steps for the patient where you see an elevated disc or an edematous disc, but there are no history or complaints to guide you. So what are the optic nerve function tests that you look for? The most objective optic nerve function test is examination of pupils. And what is more important in this patient when you are fraught with a patient with edematous looking disc is swinging flashlight test. You want to demonstrate presence or absence of relative afferent pupillary defect. That's what is very important, especially in our patient who is a 34-year-old female with a unilateral optic disc edema. So RAPD is the most important optic nerve function test in all patients who have a probable optic nerve pathology. Color vision is an important optic nerve function test as well. A screening of color vision by Ischemic chart in an appropriate setting will give you a lot of clue. Color vision can also be used to partly differentiate the pathologies which can affect the optic disc, optic nerve and optic disc, which can also cause disc edema. For example, if somebody has a normal Snellen's visual acuity, but grossly reduced color vision acuity, that's more likely in a setting of optic disc edema, you're more likely to be dealing with optic neuritis. Somebody has an optic disc edema, but the Snellen's visual acuity and a color vision acuity are parallel. If there is a moderate impairment in the Snellen's visual acuity, and if there is a moderate impairment of color vision acuity, that's more likely to be ischemia. So the two commonest optic nerve pathologies which can present with optic disc edema, color vision can be a good differentiator. Now, this is not pathognomic, but it does help you to differentiate between these two pathologies which can present to you with optic disc edema. So pupils, color vision, visual fields, which typically is tested by three methods in the OPD or in a clinical setting, and then confirmed by a formal visual fields, confrontation, Amsler, and red target. We're not going to cover that here because this is it's beyond the scope of this class. Brightness sensitivity, which is an objective, subjective way of checking pupil optic nerve function as well, and the fundus examination, which started all these structural diagnosis, because we have seen a patient who had an edematous looking optic disc. So these are uh, the optic nerve function tests that we should be performing in every patient who we see who has an optic disc edema, because as I said, it will give you a clue towards what is causing that edematous looking disc. So now our first patient, 34-year-old female, looking at the disc which looked edematous, and we did all the tests, all the optic nerve function tests were normal. So now we know that we are dealing with just the edematous looking disc. Now here I would like to introduce three definitions which are very important for us to know, especially when we're dealing with a problem of optic disc edema. One is pseudo disc edema, and papilloedema. So these are the three important definitions that one should be aware of. Pseudodisc edema is elevated looking disc without axonal swelling. True disc edema is elevated optic disc with axonal swelling, presence of fluid in the axons. Papilloedema is a true disc edema caused by raised intracranial pressure. Please remember, don't use these terms interchangeably. Sometimes we do write even a disc edema as a papilloedema. Papilloedema is the term reserved for disc edema caused by raised ICP. So use the term papilloedema only once you establish that this disc edema is caused by raised intracranial pressure. So now we have a 34-year-old female, normal, elevated looking optic disc in one eye, the other eye is normal, but the optic nerve functions are normal. So I am going to show you the picture once again, and now let's examine this optic disc in a little bit more detail and say that, okay, what is going on here? So as I said, the disc does look elevated, however. So the first thing we do when you say that, oh, we don't have any other pathology which can contribute to this appearance, you look at the blood vessels. And you can see these medium-sized blood vessels on the surface of the optic disc are clearly visible, implying that there is no fluid here. If there was a fluid here, it would obscure the appearance of this medium-sized optic disc, the vessels on the surface of the optic disc. So that will give you a clear clue that you're probably dealing with a pseudo disc edema, a clearly visible blood vessels, medium-sized blood vessels on the surface of the optic disc. So that was probably a pseudo optic disc edema. Now, we are going to talk about one more patient, and then we will go to investigations in these patients where we don't have any contributing factors. Now, we deviate a little bit and say this is now a 50-year-old female, 15-year-old female, again, coming for routine eye checkup, no visual symptoms, but complaining of occasional headache. The first patient did not have any problems, no symptoms. We looked at the optic disc and we performed the optic nerve function test. Here, this patient does have occasional headache. And this is how her optic nerves look like. Now, if you clearly look at the optic nerves do look hyperemic. If you look at the surface very carefully, you will find that there is a little bit of those lumpy, bumpy appearances on the surface of the optic disc, especially in the right eye. The left eye, you don't find so easily. You probably, if you look at it carefully and under magnification, you'll say that, oh, there are those little lumpy, bumpy appearances on the left side as well. The other thing, if you look at, is that the optic discs are small, and you find some of these vessels have anomalous loops. So now you know, again, second step, when you have this patient who has an optic disc which looks edematous, is to perform optic nerve function test, which you did, let's say, in this patient, and they also came back as normal. So in other words, in both the patients, 34-year-old female and a 15-year-old female, 15-year-old female with no contributory history have an optic disc which appears edematous. So now, obviously, we need to make sure that we do appropriate investigation to confirm, are we dealing with pseudo disc edema or are we really dealing with disc edema? And what are those investigations? You look at this, we showed this picture again, and you see that there was no obscuration in the first patient, no obscuration of these medium-sized vessels. What else can cause this kind of appearance? So this is an example of optic disc appearing edematous in patients with buried drusen. So there are no drusens visible. Some may argue saying, oh, they can see some lumpy, bumpy appearances here, but there are no clear drusens visible here. So a buried drusen can produce an appearance of a disc swelling, a cause of a pseudo disc edema. Sometimes a disc may appear, and this is from the second patient, disc may appear hyperemic or with a blurred margin, but you can clearly see a drusen on the surface of the optic disc. So buried drusen deposits under the optic nerve, visible drusen where it deposits on the surface of the optic disc. Both can cause given appearance of optic disc edema. Here you find that there is an anomalous vessel loop. So all these are obviously congenital anomalies. So you will look for other congenital abnormalities in the fundus. One of them can be these anomalous vessel loop. There can be absence of the findings which you will expect in the pathology causing optic disc edema, like capillary telangiectasia on the surface of the optic disc, presence of hemorrhages, exudates, or cottonwood spots, which are absent in these patients. So you know that there are no aligned or fellow travelers which you expect in patients with a true disc edema. So these are all negative findings that one may highlight to say that yes, we are dealing with pseudo disc edema. Again, a small disc with a small diameter of the disc and the absence of central cup can also be seen in somebody who has a congenitally anomalous disc or a pseudo disc edema. Another example, this should be easy for most of you to say that sometimes clinically confused as having a patient having disc edema is myelinated nerve fiber. Sometimes the presence of the myelination around the optic disc can give an appearance of a disc edema. There is no clinical relevance in myelinated nerve fiber except two things. One, it is critically described that presence, if you document that somebody had this myelinated nerve fiber and if it disappears later on, maybe you are dealing with demyelinating optic nerve disease. There are some papers which said that myelinated nerve fiber can be associated with amblyopia, but that's not something which is clinically proven. So now you have both our patients where you had appearance of the optic disc which looked edematous, one with a buried drusen and one with a drusen visible on the optic surface. Now, how do we confirm? There are these tests that you can perform. The ultrasound B scan can be a good way to confirm the presence of buried drusen. And here you can see that B scan is showing a hyperechoic small dot, which is present on high gain, which is also giving a high spike on A scan, corresponding A scan. So there is a hyperechoic small dot on the B scan with a high spike on A scan. This is because of the presence of calcium, and the confirmation that this being calcium is that even if you reduce the gain on ultrasound B scan, this hyperechoic spot will persist if it's because of calcium and because of the drusen. So that's one way of confirmation that you are dealing with optic nerve with buried or visible drusen. The other way of demonstrating optic nerve drusen is on fundus fluorescent angiography. These material, especially lipofuscin present in this material, can give rise to autofluorescence. So B scan will give you hyperechoic spot. Fundus fluorescent angiography, these will autofluoresce. And OCT has been now frequently used to differentiate between a true disc edema and a pseudo disc edema. You can see here the picture on the bottom. There is a smooth internal surface which is seen in a true disc edema, while here you can see this lumpy, bumpy appearance, which is generally seen in presence of a pseudo disc edema or drusen, can cause that lumpy, bumpy disc appearance. So that was our first scenario when you're dealing with somebody who has elevated disc or a presumed disc edema. So the first question you ask yourself is, are we dealing with a true disc edema or a pseudo disc edema? We said that the features like absence of, you can see the vessels very clearly, absence of the fluid, absence of other pathological signs like hemorrhage, hard exudates, or cotton wool spots, and then You can confirm by B-scan, FFA, or OCT. So these are the features of pseudo disc edema or a pseudopapilledema. Small disc, absence of cupping, anomalous branches of the blood vessels, increased number of vessels, presence of drusen, deranged peripapillary RPE, and absence of these usual suspects that you expect with a true disc edema, especially papillary. So that was the first segment. Disc edema without any symptoms to guide you. Now let's look at the second scenario where you have a patient with a unilateral disc edema with a vision loss. So here we have a 46-year-old female who has now come to you with sudden painless loss of vision in the left eye. The right eye is normal, right eye visual acuity was 6.6, left eye visual acuity was 6.24. This patient is a known case of systemic hypertension for the last 2 years, and she has been on antihypertensives twice a day, morning and night, for the last 2 years. This is how her optic nerves look like. This is the right optic nerve. One may say a patient does not have any problem here. One may say that, oh, maybe there is a pallor of the right optic disc. But I'll assure you that that's because of photographic error. Patient had a normal optic disc, normal looking optic disc. You can say that the optic disc is smaller. Here it is not highlighted, but the cup was small. And this is the eye in which patient has a loss of vision. You can clearly see that now there is a hemorrhage on the surface of the disc. There are a few not very clear. There is another hemorrhage here. There are a few telangiectatic vessels superiorly. You can see that the disc margin is blurred. You can also see that some of these medium-sized vessels now are obscured because there is a fluid. So this is a true disc edema in the setting of patient complaining of loss of vision. Obviously, we'll perform the optic nerve function test. The list I'm giving you again so that we remember it. Pupils, color vision, visual fields by 3 methods, brightness, sensitivity, and the fundus that we saw. Fundus is not really an optic nerve function test, but it gives you a clue of what may be going on in the optic nerve. So these are the 5 groups of disorders which can cause an optic nerve pathology or optic neuropathy. It can be an inflammation, it can be ischemia, it can be compressive lesion, nutritional optic neuropathy, or a hereditary optic neuropathy, where patient would have an optic neuropathy, deranged optic nerve function test, and they can have, most of these would also have optic disc edema. So you are dealing with unilateral patient with a unilateral vision loss and an optic disc edema. Generally, these 5 group of disorders in optic neuropathy, in any optic neuropathy, you need to be worried about. Now, let's go from down to below and say, can this be hereditary optic neuropathy? First question, can hereditary optic neuropathy produce, just 1 minute, please. I'm sorry for this.
Sir, you're muted.
I have muted myself with this little background. Just give me 1 minute, please. Sorry for that. Sorry for that. Yeah, so let me go back and tell you that these are the 5 groups of a disorder which you can think of. Can this be hereditary optic neuropathy? Question number 1, we are dealing with optic disc edema. So is there any hereditary optic neuropathy which would cause optic disc edema? Question is yes. Answer is yes. LHON can sometimes produce hyperemic disc in the eye with some telangiectatic vessels on the disc surface. Can it produce acute or subacute loss of vision? Yes, it can. However, we have struck it down for this patient because LHON, for all practical purposes, is disease of males. It is not seen in females because of its hereditary pattern. It is transmitted by mitochondrial inheritance, and that's why it is expressed in males. Nutritional optic neuropathy, can it produce a disc edema? Nutritional and toxic optic neuropathy, well, occasionally ethambutol toxicity can lead to optic disc hyperemia in the acute phase. Can it cause a subacute loss of vision? Very rare. Generally, it's bilateral. So that's why we have ruled it out. Compressive optic neuropathy can also cause optic disc edema. However, compressive optic neuropathy would cause gradually progressive loss of vision. So that's why we say that this is more likely to be inflammation or ischemia. Now, which one of these two would be more pertinent for us to think of in this patient? A 46-year-old female, known hypertensive, taking antihypertensives in the night, acute painless loss of vision, which is moderate. She woke up with a loss of vision. These are all, and with the other eye being small disc with a small cup, what is described as disc at risk, you are looking at ischemic optic neuropathy, especially non-arthritic variety of ischemic optic neuropathy. So what do we do next? We're talking about approach to a patient with optic disc. 46-year-old female, you're more worried about non-arthritic anti-ischemic optic neuropathy. Do we have any rule for blood tests? Well, routine blood tests are generally necessary. More and more people now would prescribe homocysteine level for these patients because hyperhomocystinemia can be associated with ischemia in the body. Carotid Doppler is, by convention, is advised because you want to rule out the presence of plaques in other arteries, in carotid arteries as well. What about neuroimaging? In a clear-cut cases of non-arthritic AIN, it was norm not to order neuroimaging because you know that this is clinically NAIN. However, as more and more different varieties of optic neuritis being unearthed, especially the antibody-mediated optic neuritis, which sometimes can be seen in middle-aged patients, neuroimaging does seem to have some role, especially if you have even an iota of doubt that this can be optic neuritis and not non-arthritic anti-ischemic optic neuropathy. So it does have some role. Whereas 15 years ago we would have said that no neuroimaging if it's clinically non-arthritic anti-ischemic optic neuropathy. So what do we do? Is any surgery, can optic nerve decompression be advised? Well, there was a trial which was done in the US which said that no, optic nerve decompression in patients with anti-ischemic, non-arthritic anti-ischemic optic neuropathy is not advisable. So what do we advise to this patient? Well, they should, the commonest causes of these patients are hypercholesterolemia, hypertension, and diabetes, and that should be controlled by the local physician. Can we advise anything? As I said, homocysteine level should be advised, and a lot of these patients can have an associated obstructive sleep apnea. So ask for a history of snoring, and then if you say that patient is obese with a thick-set neck, maybe it might be a good idea to ask for a sleep study to rule out obstructive sleep apnea. In a male patient, they should avoid using erectile dysfunction drugs because it can cause NION-like picture. Same with amiodarone. Smoking should be avoided. So that's unilateral disc edema with moderate impairment of vision. Now let's look at, so we're talking about disc edema. The first set we said no complaints. Second set, moderate vision loss in a patient who was 46-year-old. Now we say that profound vision loss. Third group, 70-year-old female, profound loss of vision in one eye, woke up with loss of vision in one eye, and she was complaining of headache. This is how her optic nerves look like. Now, this is a picture which was seen 1 week following the onset of the problem. So you see, there are lots of these cotton wool spots around the optic disc, and the disc itself has started appearing pale. while there is a blurring of disc margin, while there is a disc edema, but the disc itself has started appearing pale, one. And two, the optic nerve with the cup in the other eye is normal. There is no disc at risk in the other eye, which is a pointer towards, if this is an ischemia, pointer towards this being an arthritic AION. Now, what is the other pointer towards arthritic AION? One, 70-year-old female, that's the age group where arthritic, especially giant cell arthritis, can cause AION. Patient complaining of headache, and the most important pointer, profound visual impairment, an important pointer that early in the disease, patient has started developing pale disc. So this is a pallid disc edema, which is typically described with arthritic AION. Because the disease process in GCA is very severe, there is an acute infarct of the optic nerve. Otherwise, as I said, it takes 4 to 6 weeks for the optic disc to become pale. But these patients can develop pallor very early in the disease because of the profound ischemia which GCA can cause. And that's the reason why acute pallid disc edema, profound visual impairment in 70-year-old female, you know that you're dealing with arthritic AION. How do you confirm it? You can confirm it by clinical examination, asking the history points. History of weight loss, history of migrating joint pains, polymyalgia or metica, and history of painful mastication or difficult mastication, jaw claudication. So history of weight loss, history of migrating joint pains, jaw claudication, night sweats, these are all pointing, and of course, bitemporal headache, these are all pointers towards giant cell arthritis. What's the next step? Obviously, this is as we know, and in the exam we are supposed to say that if you suspect a patient having a giant cell arthritis, presenting with arthritic AION, it's a medical emergency. That patient has to be admitted. ESR blood has to be drawn for ESR, CRP, and platelets, and the patient has to be started on steroids immediately. Why immediately? Well, there is a very little chance that you'll be able to reverse the vision in the affected eye, but these patients can have effect of this ischemia in the other optic nerve in the matter of few hours, and that's the reason why these patients should be given steroids immediately, as we have mentioned here, in hours and days. Of course, the process is a generalized process. The patient can develop stroke or other ischemic events like myocardial infarction, or anywhere else in the body the infarct can occur. That's the reason why steroids very important, and then the rheumatologist has to be brought into the play to manage these patients. Temporal artery biopsy of the same side or the other side or both sides can be confirmatory in these patients. So we spoke about swollen optic disc. First one was swollen looking optic disc, no complaint. Second one was swollen optic disc with loss of vision, either moderate or profound visual impairment. And we spoke about both types of ischemic optic neuropathy, which can come to us with swollen optic disc. Now, the question is, we kept talking about this being AION. Can it be optic neuritis? Yes, it can be optic neuritis. Now, the NMO and MOG associated, what is described as atypical optic neuritis, can cause optic disc edema. How do we suspect that can this be an optic neuritis? Well, these patients can have bilateral presentation, patients with NMO and MOG related optic neuritis, very severe vision loss on presentation. They don't respond to steroids. There can be recurrence. There can be other neurological deficits, especially patients who have NMO, MOG, NMO, aquaporin antibody related optic neuritis can complain of frequent hiccups. And that's something which tells you that you are dealing with Devick's disease or neuromyelitis optica. As these are the associated neurological symptoms that one should be looking for, like weakness, painful spasm, loss of sensation, uncontrollable vomiting or hiccups, and bladder or bowel dysfunction. So these are features of, again, 15, 20 years ago, somebody who has an optic neuropathy in a middle-aged, we say that it's much more likely to be AION. However, we know that especially NMO and MOG-related optic neuritis can occur at any age. MOG-related optic neuritis can have a bimodal presentation early in the life and also later in the life. And MRI can give you a clue, especially for NMO-related optic neuritis. If you have hyperintense signals in these areas, which generally Other cause of optic neuritis will not produce hyperintensity in, let's say, optic tract, long segment of optic nerve, dorsal midbrain. You know that you are dealing with optic neuritis. And same with MOG. MOG in the MRI will produce a very thick nerve, what is described as perineuritis. They can be monophasic, but they can have recurrences as well. MOG-related optic neuritis is a better recovery than NMO-associated optic neuritis. So in other words, patient with optic disc edema, unilateral presentation, or asymmetrical bilateral presentation with vision loss, it can be both inflammation and ischemia. And that's the reason why I said that some of these patients, it might be prudent, if you're not absolutely certain that you are dealing with ischemia, then it might be prudent to request for MRI brain and orbit with contrast to make sure that you're not missing out on antibody mediated optic neuritis. So approach to patient with optic disc edema with vision loss, two important acute vision loss, two important pathologies that we need to worry about is inflammation and ischemia. And sometimes they can be differentiated clinically. If they are not, we are not able to differentiate it clinically, go for neuroimaging. So that's disc edema unilateral. Now let's look at bilateral disc edema. 24-year-old female complains of persistent headache, very mild visual problems, and visual is 6/6 in both eyes. And you find here there is a clear, true disc edema. You can't see the blood vessels on the surface of the optic disc. You see these hemorrhages on the surface of the optic disc. You know that you're dealing with bilateral, true disc edema. 24-year-old female complains of headache. So your first job is to say, can this be, are we dealing with raised intracranial pressure? The other important pathology, which is often forgotten, is malignant hypertension. Not in this patient, but somebody who has a bilateral disc edema. Always make sure that you check the blood pressure to make sure that you're not dealing with malignant hypertension. So here you know that this patient, 24-year-old female, complains of headache. Now, what are the other features that you want to look for? You want to look for her BMI to see whether she's overweight. Two, the other associated symptoms, because you want to rule out now raised intracranial pressure, because raised ICP would cause bilateral disc edema in the presence of normal visual acuity. The patient had a 6/6 vision with a very mild visual symptom. So what are the other history points that one will ask for to confirm that we are dealing with raised ICP? Apart from complaints of headache and vomiting, please remember projectile vomiting is often answered as a first symptom that one should ask for. Projectile vomiting can be seen in raised ICP, but would be seen more in raised ICP because of meningitis. Those patients who have raised ICP because of meningitis are less likely to be presenting to us in ophthalmology OPD. They are more likely to be present in the ward, and then we will be seeing them as a secondary referral. However, it can be seen in other causes as well, but more likely to be meningitis. So we say headache. The other symptoms that one would ask for in these patients is transient visual obscuration. Transient visual obscuration is an important symptom of raised intracranial pressure. The characteristic of transient visual obscuration in the presence of raised ICP are that they last only for a few seconds. It is associated with change of posture. It is typically described as browning out of vision. So if you have these three characteristics, you know that you probably are dealing with raised ICP. We should ask for history of tinnitus, whooshing sound in the ear. So transient visual obscuration, tinnitus, whooshing sound in the ear, and headache are important features of raised ICP. So when you have a patient with bilateral disc edema, which is with a very mild visual symptom, you know that you want to rule out raised ICP, and you will do this by asking those questions. Now let's see what else in the ocular motility that one can see. Rarely, I'll not say rarely, in a sudden and profound increase in intracranial pressure, these patients can have bilateral 6-nerve palsy, what is also described as false localizing sign. Now, what are the visual field findings in the patient who is likely to have raised ICP? In an acute papilledema, patient will have enlarged blind spot. In a chronic papilledema or a little advanced disease process, you will have these kind of peripheral constriction of vision. So if you see a patient on a visual field who has a tunnel vision, your differential diagnoses are chronic glaucoma, retinitis pigmentosa, and chronic papilledema. That is an important differential diagnosis for patient having a tubular vision or tunnel vision. Um, OCT is a good objective way to follow up these patients, because these patients can have, in an acute phase, they can have a massive disc edema. As you can see here, the numbers are really off the roof. So that's an RNFL. And then if you look at the ganglion cell cube, you see that there is a depressed ganglion cell cube. This is where our role as an ophthalmologist comes in. Neurologist does not have an access to this data that patient has an increased average RNF thickness, which is of course because of the disc edema, but has a depressed ganglion cell function, implying that the disease process is now have started affecting the papillomacular bundle, and that the treatment should be aggressive. So OCT has a good role to play in somebody who has a bilateral disc edema because of raised ICP. Visual fields and OCT should be done to make sure that we contribute to the diagnosis and management of these patients. So if you have a patient with raised intracranial pressure, you need to rule out other pathologies. And if there are no pathologies which are present, then you know that maybe you're dealing with IIH or idiopathic intracranial hypertension. Uh, the neuroimaging that you need to, and please remember, if the neuroimaging was not done, and if you are suspecting patient as having papilledema, then that's a medical emergency, and immediate neuroimaging is warranted to rule out presence of space occupying lesion. If the patient has raised intracranial pressure and a space occupying lesion, it can lead to, very quickly can lead to brainstem herniation, which can be fatal, and that's the reason why it's an emergency. Once you have ruled out a space occupying lesion in raised suspected papilledema, then the other investigation of choice would be MRI with MRV with contrast. What are we looking for? In MRI, we are looking for widened perioptic spaces. We're looking for other features like empty cella. And in MRV, we're looking for venous sinus thrombosis. That's something which is very, very important. These are the signs and symptoms that we look for, and treatment option is beyond the purview of this. So now we are talking about bilateral disc edema with a suspected papilledema. You do complete neuro-ophthalmic examination, as I mentioned, check blood pressure, MRI and MRV, and the lumbar puncture. Often we are asked, that textbook says that lumbar puncture is contraindicated in raised intracranial pressure. Well, no, lumbar puncture is contraindicated if if you don't know the pathology, or the pathology is because of the tumor sitting in the brain. Why? Because in those patients, if you lead to sudden decompression, it can itself lead to brainstem herniation. However, once we know that there is no structural lesion in the brain, then lumbar puncture is important for you to document the opening pressure and also presence of composition of cerebrospinal fluid to see if there are any infections or autoimmune disease which is causing increased turbidity of cerebrospinal fluid, leading to raised intracranial pressure. So that's about bilateral disc edema because of papilledema. However, again, our role as an ophthalmologist is very important, as exemplified by this 10-year-old female who presented to us with the complaints of reduced vision for the last 4 months. 4 months ago, she had gone to neurologist with the complaints of headache with no vision symptoms. Neurologist admitted the patient because on a direct ophthalmoscope, they found that there was a disc edema, which was still persisting even 4 months later. So there would have been some amount of blurring of disc margin in a patient who was complaining of headache. Ophthalmologist was called to the ward for examination, and ophthalmologist saw the patient and said that yes, there is a disc edema in the ward. So a patient was instituted with Diamox. Patient kept losing vision with Diamox slowly, and that's the reason why she came for a second opinion. Remember, in the first instance, patient never got a complete ophthalmic examination. So when the patient was checked on the slit lamp, she was actually found to have multiple vitreous cells in both the eyes, and the vision loss was because of cystoid macular edema. So patient actually had bilateral intermediate uveitis causing vitreous cells, causing disc edema, and a vision loss was because of uncontrolled cystoid macular edema. So a complete ophthalmic examination, while disc edema is because of, in a lot of instances, is because of neurological problem like raised ICP or inflammation of optic nerve or ischemia of optic nerve. But an ocular condition like uveitis, posterior uveitis, intermediate uveitis, or hypertony can also cause disc edema, which is an important feature one should always remember. These are some of the pictures of ischemia for us to look at. This is a malignant hypertension. How do you know? Because a lot of findings way away from the optic disc with changes in the blood vessels. So if you find that findings are away from the optic disc, peripheral fundus, with the blood vessel changes, you know that you're dealing with malignant hypertension. This is neuroretinitis with disc edema and a macular star. This is a sectoral hyperemia with pallor. You can see here this is BRAO with pallid disc edema, arthritic AION. Here there is a ciliatal artery, ciliatal opticociliary shunt because of the compression of the optic disc, also causing disc edema. Here there is a disc edema because of hypertony. You can see that there is a overfiltering bleb here. So bilateral optic disc edema, which is not papilledema, these are some of the causes. I'll end with a little uncommon cause of an optic disc edema, but nonetheless very important. A 46-year-old male comes to you with a sudden painful loss of vision in the left eye. He had had redness of this affected eye 3 days ago. For that, he went to an eye examination locally, and at that time, his vision in the affected eye was 6/9. So he had some redness, little blurring in the left eye. Visual acuity in the right eye was 6/6, and the left eye was 6/9. However, when he came 3 days later, 6/9, and 3 days later, vision actually had become no PL in the affected eye. And patient actually had a disc edema, this angry looking, severe disc edema with lot of hemorrhages. And if you see carefully, there was a rot spot. Okay, there is a white centered hemorrhage. So here is a patient who went from 6/9 to no PL in no time with an angry looking, very elevated optic disc. Generally, this kind of disc picture can be seen in infiltrative optic neuropathy, and as exemplified in this MRI, it's a very thick nerve. So infiltrative optic neuropathy can also cause optic disc edema. Why it is important for us to know? Because well, it didn't happen in this patient, but there have been instances where leukemia has been diagnosed by ophthalmologist, because patient comes to you with like this, with an acute loss of vision. Patient undergoes MRI. Patient is found to have infiltrative optic neuropathy. He undergoes a routine blood examination and is found to have leukemia. Leukemia can cause infiltrative optic neuropathy, and it can also cause this kind of white-centered hemorrhage. So that's something which is very important to know. So infiltrative optic neuropathy can also cause optic disc edema. So here, if you have a patient with bilateral optic disc edema, it can be a true edema or a pseudo-papillary edema. If it's a true edema, it's a vision loss, it can be bilateral optic neuropathy. But if there is no vision loss, then you do MRI and see whether is there any structural lesion. If there is a structural lesion, it can be papillary edema. If there is no structural lesion, but the lumbar puncture is also showing a raised intraretinal pressure, it is still a papillary edema. If lumbar puncture is normal, then it can be other causes like Guillain-Barré syndrome, spinal cord tumor, and whatnot. So to conclude, if you see a patient with disc edema, these are the questions that you need to ask yourself. Is it just an elevated disc, or is it really a disc edema? Is the problem unilateral or bilateral? What is happening with the optic nerve function test like pupil, color vision, and visual fields? Is the optic disc edema coming from the optic nerve itself, like swelling of the optic nerve or ischemia of the optic nerve? Is it coming from above, that is from the brain? Is the optic nerve getting pressed from the brain like papillary edema, or is it coming from below? Is the problem coming from the eye like uveitis or hypotony? And this is true for both elevated or even pale looking disc. What do we do next apart from history? You look at the optic nerve function test. Look at the blood vessel and the retina. Sometimes the blood vessel and the retina, surrounding retina, can give you a clue if there is a presence of hard exudates, if there is presence of other choroiditis patch. You know that the disc edema is because of uveitis and not because of anything in the brain. So look at the uveitis. Look at the systemic association to make sure that you're not you're not missing out on any other causes of optic disc. So this is an important topic for a full question, for a viva, and also for a patient who you might find a patient or a photograph in the viva. So you make sure that you have this algorithm that we discussed in your mind and approach it clinically. I thank Prafulla, Pranita, and entire team from DOS for giving me this honor. Thank you so much.
Thank you so much, sir. And you rightly said this is a very important topic, and that's why I requested you to take this lecture. And Abhip sir,
Yeah,
and
good
yeah,
evening.
Abhip sir, are there any questions from the student?
So, just a few questions. Just a cause of pseudopapilledema as PHOMS is what we are reading nowadays. Can you elaborate on that, Dr.
No, so
Ashwin?
so that's basically a terminology which is given, which encompasses the entire gamut of all the different accumulations that you have in that space. So, and why we have given that terminology, because that's more like an OCT diagnosis. So you look at the OCT to find those different signs of OCT. I didn't want to cover that too much in detail because that's probably a little away from our target audience. But PHOMS, it's good to know that PHOMS is an OCT, by and large OCT diagnosis of a pseudo disc edema, where you have entire gamut of different accumulation within the optic disc surface, on the surface or below the disc surface, which gives rise to different changes in the OCT, in the contour of the optic nerve, in the different angle at which the vitreal optic angle is seen, and various other changes in the Bowman's membrane.
Another question is, are there any telltale signs of previous optic disc edema in a patient in which you are, seeing as an optic atrophy after raised ICP or after a unilateral disc edema?
So it depends upon, that's a very good question, depends upon how many days later you are examining a patient. Now, let's say if you've seen patient 2 months after patient had a disc edema and the disc has become pale, you will still see some amount of blurring in a pale disc somewhere in the disc margin. You may still find some amount of concentric folds along the choroid, which will tell you that maybe this patient had a disc edema. Later on, once the axons are completely died down, then it's very difficult to say whether patient had disc edema, whether this is a secondary disc edema or a primary disc edema. Very rarely you may find a gliotic changes radiating from the optic disc along the axons, but that's not very common.
Okay, so another question is, what is the role of FFA in, evaluating patients of disc edema?
So there are two things. One, of course, now the role has been it has become marginal in patients with disc edema, because obviously it's an invasive procedure and you have a better non-invasive procedures available. But there are two things. One is on autofluorescence. It'll highlight this lipofuscin and calcific material. So autofluorescence generally in a presence with optic disc drusen. And now you need to differentiate between a true disc edema or a pseudo disc edema. A true disc edema will always show some amount of leakage. Now, leakage can be early or late. A late disc staining can be seen in an inflammatory pathology, while an early disc leakage can be seen in somebody who has a pressure-related problem. So, a good question, but clinically, it's little less relevant now because of this being an invasive test.
Okay. So, are there any changes which can differentiate? You look at a disc and there is a disc edema. So, can you diagnose from the disc or around the disc what could be the pathology?
Yes. So now let's say we looked at 4 pathological causes of disc edema. One is inflammation, second is ischemia, third is infiltration, and fourth is raised ICP. So let's go to ischemia. If it's a non-arthritic AION, then you'll have a sectoral disc edema. So you're much more likely that one half of the optic disc would be swollen and the other half would not be swollen. So if you find that in a small disc, maybe you're dealing with NAR. There is a large disc but infarcted in an acute phase. So looking at the disc, very severe disc edema, let's say in the first week itself with pallor, you're dealing with arthritic AF. If you have a bilateral disc edema with surrounding a lot of hemorrhages, hard exudates, cotton wool spots, maybe you're dealing with either malignant hypertension or raised ICP. And the optic neuritis, generally it's more likely to be a global optic nerve swelling. So you can get a clue from the size and the fellow travelers.
Yeah. Thank you so much.
Thank you so much, sir. I think the last question and the explanation to that is very invaluable to the students as well as physicians like me who are not doing neuro anymore but still doing an OPD.
Thank you.
And from DOS, sir, this is a small certificate of appreciation to you. And I'm sure you'll join us for our annual DOS. And then we'll give you this in the frame certificate form. And Pranita, are we anything in the students portal or can we close
Yeah, I
here?
think that is it. And we're really thankful to Rashman sir for that comprehensive class and that case-based discussion. I think really added a lot of value. I think the student must have benefited a lot from the class.
Thank you so much.
And in this module, sir, this is the first of its kind, and we really enjoy that.
Thank you. Thank you so much. I'm really honored that you give me a chance. It's always pleasure to speak to all of you guys. Thank you so much.
Thank you, sir.
Thank you, sir. Yeah, Pranita, conclude.
Yes, so with that, we'll come to an end of this class. And thank you, sir, for being here with us. And thank you, Abib, sir, for moderating this session. And with that, we'll close this class. Thank you and good night, everyone.
Thank you.
Thank
Thank you,
you.
Abisa, for lovely
Thank you.
questions. Thank you.
Thank you. Thank you. Good night.
Good night.